Yes, my privilege to introduce Marion Müller and Ido Richard. So they'll introduce themselves, but it's Symposium III. Marion, Ido, please.
Thank you, Raj. Well, welcome to this session on cardiovascular risk management throughout the life course to prevent or treat dementia. And I first want to start to thank for the invitation and thank the organizers, Raj, John, and you for this beautiful conference. Unfortunately, it's not live, but it's very good to see you all through the screen. Let's introduce ourselves quickly. My name is Marion Müller. I'm a professor of internal and geriatric medicine, and in particular cardiovascular aging, and working in the Amsterdam University Medical Center. And my co-chair and presenter is Ido Richard. He's a professor of neurology, and in particular the vascular component of dementia at the Radboud University Medical Center, and both in the Netherlands, of course. So the layout of this presentation is that I will start with a short introduction on prevention on dementia throughout the life course. And then Ido will present on cardiovascular risk management to prevent dementia, and I will end with some slides on cardiovascular risk management to treat dementia or to prevent further decline. So can I have the next slide? Yeah, thank you. So worldwide, around 55 million people have dementia, with over 60% living in low and middle income countries. And the number of people with dementia is increasing in the absence of any effective treatment, and also the increase in life expectancy. So, and it is expected that in 2030, 70 million people will have dementia, and it will further increase to 120 million people, mainly in low and middle income population. So in this view, preventing or delaying dementia onset is one of the global public health priorities. And recent studies have shown that a reduction of dementia incidence in developed countries, possibly due to better lifestyle and cardiovascular risk factors management. So the Lancet International Commission on Dementia Prevention, Intervention and Care has pointed out that approximately 30 to 40% of dementia cases could be attributable to modifiable risk factors. And these modifiable risk factors present in different life periods. So aging of the brain and related cognitive decline is not determined in any single period in life, and probably results from the complex interplay of exposures throughout the life course. And so with age, first cognitive function increases and then it decreases throughout late life. Next slide, please. And that will result either in having subjective cognitive complaints, mild cognitive impairment, or dementia. But the trajectory of cognitive function and speed of decline is depending on exposure of to endogenous and exogenous risk factors throughout the life course. So the individual trajectory is depending on all this interplay of factors, starting with, for example, genetic factors in early life, education and lifestyle factors during childhood and young adulthood, and exposure to cardiovascular risk factors and disease in midlife and later life. So this suggests that there are optimal time windows for targeting risk factors to prevent cognitive decline and dementia. Next slide, please. So different prevention strategies can be used for different life stages. And these prevention strategies include universal prevention, which refers to approaches designed for an entire population aimed at enhancing public health. And with respect to dementia prevention, it should start at early age or childhood and target, for example, education levels and lifestyle factors such as diet. Another prevention strategy is selective prevention. And selective prevention is targeting subgroups of a population determined to be at high risk for dementia. For example, those with cardiovascular risk factors such as diabetes or hypertension. And these risk factors most often emerge during midlife. Or maybe, as Martin suggested, persons with a certain genetic profile could be a high-risk group. And finally, indicated prevention is when interventions are aimed at individuals already showing signs of cognitive impairment. And these prevention strategies are more targeted for small groups, individuals, and with respect to dementia prevention, aim to prevent further cognitive decline. So Edo will now continue focusing on cardiovascular risk management to prevent dementia. He has extensive experience with large clinical trials into the prevention of dementia and cardiovascular disease using multi-domain interventions, and he will discuss where we stand and whether dementia really can be prevented. Edo.
Thank you very much, Marion. And before we talk about the actual interventions, we really need to consider who our target populations are. And for this, it's important to realize that most of our knowledge on risk factors in dementia comes from studies in the 90s and the early zeros of this century. And the question is whether our current population in their 60s is still comparable to the populations that were studied earlier. Because those who were studied in the 90s or published in the 90s, they were born in the 30s. And quite some things happened in between. Next, please. There's been a world war, for instance. TV was invented, we started driving cars, and the World Wide Web was invented. So this completely changed our society. Next, please. And moreover, education improved dramatically in large parts of the world, healthcare improved, and migration really changed the essence of our populations. Next. And nutrition improved dramatically, although over the last decades it may deteriorate in some high-income countries again. And we started massively prescribing antihypertensive drugs and statins. Next. And the risk factors themselves, they changed. Finally, after years of campaigning in high-income countries carefully, people stopped smoking. But this comes on the other hand with an increase of body mass index and an accompanying increase in diabetes again. So the question is whether our population who is 60 now is still comparable, and we can really use the knowledge that we have from these older studies for the current populations. And as Marion already said, we need a life course perspective, but the difficulty is that the different risk factors exert their most detrimental effects at different moments in life. And moreover, this is probably dependent on comorbidity as well. So this clearly illustrates that one size of risk factor management will certainly not fit all, and we really need to work towards more personalized prevention strategies. Next, please. And to make matters more complex, several of these risk factors actually do not have a linear relationship with the risk of dementia. If you look on this graph, on the y-axis is the risk of dementia, and on the x-axis any risk factor. Let's take blood pressure as an example. We know that the high blood pressure is associated with an increased risk of dementia, but so is a low blood pressure. So a so-called J-shaped curve appears. And to make matters even more complex, next please, this curve probably shifts with increasing age. And this results in that we do not know that for who, at which age, with which comorbidity, what the optimal blood pressure is. And even more so, we do not know that if we treat the blood pressure towards this so-called optimal blood pressure, which we know from observational studies, whether this will eventually lead to the prevention of cognitive decline or dementia. Next, please. As Marion already said, about 30 to 40% of all dementia is probably attributable to a series of potentially modifiable risk factors. And several groups have studied this. And I quote here people from Cambridge who did the CFAS study with Carol Brain in the lead. And they calculated what would be the result if we would reduce these risk factors by 10 or 20% over the next decades. And I think we should be modest. If we would reach 10% reduction, this would be fantastic because it's hard. Prevention is hard work and it's difficult. And if we would reach this 10%, this would translate in probably around 8% reduction of the prevalence of dementia by 2050. And although this may seem modest, this would equate to over 10 million people in absolute numbers. So I think this is really worthwhile. But this is theory, so much for the theory. What if we put this to the test of randomized controlled trials? Next, please. To do this, we did the prevention of dementia by intensive vascular care trial, the PREDIVA trial. So far, the only study really using all-cause dementia as primary outcome. This was a pragmatic cluster randomized controlled trial, completely executed in primary care, where we invited all people between 70 and 78 from 116 primary care practices. And about half of all invited wanted to participate. So I think this comes pretty close to population representative, or at least as close as you can probably get for a trial. And we then cluster randomized by practice, and the whole practice received either standard care or intensive vascular care, which comprised of 4 monthly visits to a practice nurse. And this started in 2006, and the final visit was in 2015. And after 6 to 8 years intervention or control, 7% developed dementia in the control group versus 6.5% in the intervention group. Next, please. And this yielded a hazard ratio of 0.92 with a confidence interval widely overlapping 1. Or in other words, we were not able to show that with this generic approach at a broad population, we could reduce the risk of dementia even after such a long intervention period. Next, please. We did a series of pre-specified subgroup analyses, and I'd like to highlight one. And this is the subgroup analysis for those with untreated hypertension, because in this group of people, the effect size was much larger with a hazard ratio of 0.69, and even more so if those people were adherent to the intervention. Now, of course, interpretation of this type of subgroup analysis should be with great caution. So I don't think this is convincing evidence, but I do think this confirms that our approach, which seems sensible in 2005 to do a broad use a broad target population, was probably not the optimal approach, and we should target high-risk populations, for instance, those with untreated hypertension. Next, please. We recently completed a 10 to 12 year extension of the follow-up, so 10 to 12 year from baseline of the trial. And we had still virtually complete information on the primary outcome, all-cause dementia, which is a major advantage of such a pragmatic outcome. And we saw a similar signal, so a hazard ratio of 0.99. So there was also not a delayed effect, which you may have expected with this type of intervention. Next, please. But there are also other studies which are a little bit more optimistic and a little bit more promising, particularly for hypertension treatment. There's the SPRINT MIND, which was a pre-planned sub-study of the SPRINT trial, in which people with hypertension were randomized to a target of below 140 or below 120. The study was relatively short for this outcome, 3.3 years, but this was because the study was terminated early because of a statistically significant and clinically relevant effect on primary cardiovascular endpoints. There was an extended follow-up up to 7 years for cognition, and in the end, 3.5% of the population developed dementia. And for the primary outcome of the SPRINT MIND, dementia, there was a hazard ratio of 0.83, which was not significant. And as you can see from the survival curve, this effect is almost completely attributable to very late extended follow-up, where the numbers at risk in the study were actually relatively small. The authors also combined the outcomes dementia and mild cognitive impairment, which yielded a similar hazard ratio, but this time statistically significant, probably because of the larger sample. And although this is promising, and I really think this is a clear signal that blood pressure treatment may lead to the reduction of cognitive impairment and dementia. Next, please. Mild cognitive impairment is a tricky outcome because it's not always what it seems, especially when assessed in a research setting where people do not present with cognitive complaints, because we know that a considerable proportion of people who are labeled as MCI in prospective studies without cognitive complaints return to normal at the next visit in their observational study. So this is a very unstable outcome measure. But in spite of these limitations, I do think these results are really encouraging. Next, please. And together with researchers from the FINGER trial and the MAPT trial to other multi-domain intervention trials like Prediva, we teamed up and we did healthy aging through internet counseling in the elderly trial, where we asked the question, can we reduce the risk of cardiovascular disease and dementia with an e-health intervention? Now, you may wonder why e-health, but then I'd like you to think of one of the first slides of Mayon, which showed that the expected increase in prevalence of dementia is completely attributable to low and middle income countries where people usually don't have access to proper preventive health care. And e-health may offer an excellent opportunity to reach large numbers of people who live remotely and don't have proper access to regular preventive health care. Next, please. So for this project, we developed an e-health platform specifically designed for older people to be very simple and intuitive. And this took us about 2 years. This was a great effort. Next, please. And for this, we based ourselves on the learnings that we drew from Prediva, from FINGER, and from MAPT. We did focus groups with the target population, with nurses, with doctors, to ask them what they thought that such a platform should look like. We did a systematic review on e-health interventions for cardiovascular risk management to get some more substance of what we should approach. And of course, we adhered to all current guidelines for cardiovascular risk management. And we integrated all this information into this platform, which was focused completely on self-management, on goal setting, and it was interactive. People could add their own values, get graphical feedback, and it was supported by a coach, a real human being that all participants saw during baseline, because we know that this type of blended approach with e-health and a human being actually leads to larger effect sizes. Next, please. So we targeted a population of people over 65 with an increased risk of cardiovascular disease and dementia, with at least 2 risk factors or manifest cardiovascular disease. And we eventually recruited 2,724 people from the 3 participating countries, the Netherlands, Finland, and France. And we randomized those people to use of this interactive platform with a coach or a control condition, which was a sham platform with only static health information. And this intervention lasted for 18 months, and our primary outcome was a composite score of systolic blood pressure, LDL, and BMI. Now, of course, this is not a clinically relevant outcome, and we would have preferred to look at cardiovascular disease and dementia, for instance, but this sample size and this study duration does not allow for this kind of analysis with sufficient statistical power. So as such, I think this is a very large proof of concept trial. Can we actually use e-health to target elderly people with and improve their cardiovascular risk profile? Next, please. And I'll show you only the results for the primary outcome, our composite outcome of the 3 risk factors. This is depicted as a Z-score on the y-axis, so standard deviations. And you see that both the control and the intervention group slightly improve. Lower is better in this case. And the intervention and the difference is 0.05 standard deviation in favor of the control group. So the composite of systolic blood pressure, BMI, and LDL improved more in the intervention group. Now, this difference is very small, 0.05 standard deviation of this score. And although statistically significant, the question is, of course, whether this will eventually translate into the prevention of cardiovascular disease, stroke, and dementia. This we don't know, but I think at least this shows the proof of concept. This kind of approach is possible on a large scale. And even though the effect size is small, if achieved at the population level, it may certainly be worthwhile. Next, please. We complemented this with a Cochrane systematic review, which is currently in the final stages of the review process and will soon be published, where we looked at all studies doing multi-domain interventions to prevent cognitive decline in dementia. And we found 9 studies of sufficient methodological quality. And these were considerably sized studies with a mean sample size of 2,000 participants, but with widely ranging follow-up periods of 12 to 120 months. And only 2 studies looked at dementia as outcome. And we found a risk ratio of 0.94, comparable to what in Prediva alone was found. Some more studies used cognitive decline using a neuropsychological test battery as an outcome. And for this, we calculated the standardized mean differences because they used different scores. And the standardized mean difference was 0.03. Again, this is statistically significant, but very small. And of course, the question is, will this eventually translate into detectable effects on cognition or even prevention of further progression towards dementia? So some encouraging results as well here, but certainly not convincing yet, unfortunately. Next, please. And then something about timing, what Mayon already said. I think timing is everything. If you look on the y-axis in blue here, you see the effect of an intervention, let's say a multi-domain intervention. This is probably largest in midlife, and the effect is probably relatively low in old age. Next, please. If you look at the right y-axis in red and you look at dementia incidence, obviously you see the opposite. The incidence is very low in midlife and only starts to rise dramatically after the age of 70 or even 75. Next, please. So even if you would have an effective intervention in midlife, it would take tremendously long to detect an effect on your outcome of interest. And I think in Prediva, we were pushing the limits with up to 8 years in a randomized phase. So the question is whether this type of studies are actually feasible. Next, please. So where the optimal window for intervention is in midlife, the optimal window for outcome assessment is in late life. So how to solve this problem? Well, one solution would be to be pragmatic and target people a little bit in between late midlife and still have a considerable long follow-up for outcomes of interest and have a very large sample size. And I think this would probably answer the questions that we are addressing. An alternative scenario would be to use intermediate or surrogate outcomes. But then you have to be very sure that these outcomes, that an effect on these outcomes will eventually translate into clinically relevant effects. And I think an excellent example here is anti-amyloid therapy in Alzheimer's disease. These drugs are very potent in removing amyloid from the brain, yet none of the trials published so far has ever shown any clinically relevant benefit for patients. So using a biomarker as outcome will still only result in phase 2 evidence, and you will still need evidence on clinically relevant outcomes. Next, please. So finally, who should we target? At the top of this graph, I depicted the distribution graphically for the risk of dementia and the prevalence. So at the far left, people with a very high risk of dementia are relatively rare, but people with an intermediate or lower risk of dementia are much more common. So if you would target those at a very high risk of dementia, you are most likely to have a larger effect at the individual level, but the potential impact at the population level will be limited because the number of people at very high risk is so low. So if you would target people with an intermediate or lower risk, the effect for an individual will be very small, but in the end, the effect for the population will be much larger. Next, please. And I don't think we need one of these approaches. I do think we need both. So you can select people for highly targeted therapies who are at very high risk of dementia using advanced diagnostics. For instance, use MRI parameters, PET scanning, CSF, blood, or maybe even genetics. Martin really showed us that there's a future, and the future is not so far away for really targeted therapies based on genetic risk. But the impact on the population level will be small. So at the same time, we need large trials from a population perspective, where we need selection parameters which are easily implementable across the globe, also in low and middle income settings. Simple parameters such as demographics, anthropometry, blood pressure, or for instance, family history, which I think is an excellent low-cost genetic marker. Next, please. So in conclusion, can we use cardiovascular risk management to prevent dementia? Well, I think the promise from observational studies with 30 to 40% of dementia attributable to modifiable risk factors is simply not supported by the trial results so far. Results are ambiguous and I would say are moderately encouraging, at least for treatment of some risk factors, such as blood pressure. I think the target population and target values are really uncertain, and we need really more work on this to work towards better personalized prevention strategies. And very important, I think we need to realize that results from the past may not be applicable to our current generation of people in their 50s and 60s anymore. So I think we do need long, large, pragmatic trials with clinically relevant outcomes. These are really welcome. And I also think that we should be careful designing new, short, relatively small trials using a comparable approach, because it's very unlikely that any of these trials will really change the conclusions above, unless really doing something new, targeting a completely different target population, highly selected, or use a completely different intervention style. So this was what I wanted to say about prevention of dementia, mostly from a population perspective. And from here, Marion will continue, and she will discuss the challenges along this continuum, preventing further cognitive decline in those who already have cognitive impairment. And Marion has extensive experience studying the connection between cardiovascular disease and dementia. And the strong point is that as a geriatrician, she focuses on this interplay in older persons who she really sees in daily practice every day. So Marion, please continue, and we will take the questions afterwards.
Thanks, Edo. So let's shift to a later phase in life. And what should we do with respect to cardiovascular risk management when people already are cognitive impaired? What to do? So to make decisions on whether or not to treat cardiovascular risk factors in dementia patients to prevent further cognitive decline, it is important to take into account the following. You have to take into sort of estimate what is the remaining life expectancy of a person. Also, what is the time to benefit of a treatment you want to start. And also, are high blood pressure and high cholesterol levels still risk factors for adverse events and further brain damage in these older patients with already cognitive impairment? And finally, is there any evidence on whether treating cardiovascular risk factors prevents adverse events in patients with already cognitive impairment? Next slide. So it is known that from several studies that both in men and women with dementia, they have significant reduced life expectancy compared to those without dementia. And this is shown in this table, where you can see that those with dementia have shorter life expectancy than those without, with the most pronounced difference in life expectancy in younger age categories. This is important to realize with respect to starting treatment. Next, please. Every drug and medication has a time until benefit, which is an estimate of the time needed until a treatment becomes significantly effective. For example, painkillers have a very short time until benefit in the range of minutes or hours. However, the time to benefit of preventative drugs as antihypertensives and statins are longer and more in the range of years. So when persons have a long life expectancy, goals of care are to prevent diseases. Next, please. And there is a large number of appropriate medications, including those with long time to benefit. But when life expectancy is reduced, as for example in dementia patients, goals of care shift from preventing diseases to treating symptoms and maybe even palliative care. And as a physician, you should consider maybe even to de-prescribe medication. So this is always something to take into account when you see a patient with dementia and you want to start treatment. Next. Then are high blood pressure and high cholesterol still risk factors? And there is some data on the trajectory of blood pressure levels and cholesterol levels with aging. And the first graph shows that approximately 10 to 12 years before death, blood pressure levels decline. And in this study, this was largely explained by patients who had dementia, heart failure, and weight loss. The second graph shows similar results for cholesterol levels with declining cholesterol levels with age, both in men and women. And Ada already talked about the U-shape relation. We know that both high and low levels of both blood pressure and cholesterol are related to adverse events in older patients. Next, please. Again, next, I'm sorry. And this U-shape relation is largely explained by frailty and comorbidities. So in older, frail patients, not high, but low levels of cholesterol and low blood pressure levels are related to adverse outcomes. And it is possibly because of reverse causality. So in other words, low blood pressure and low cholesterol levels, they decline with age and comorbidity and are most likely risk indicators and represent underlying disease. So what about treatment? Next, please. Is there any evidence from randomized studies? So Ada already talked about the SPRINT study, and the SPRINT shows beautiful results in reducing risk of cardiovascular events, death, and also cognitive impairment with with blood pressure targets, intensive blood pressure targets. However, dementia patients and patients with cognitive impairment were not included in the SPRINT study. So we don't know if it's also applicable to patients with already cognitive impairment. And we do know from an observational study that lowering blood pressure levels was associated with change in MMSE score. So patients with both dementia patients and patients with mild cognitive impairment with lower blood pressure levels showed a cognitive decline in follow-up. And this is shown in this graph. Next slide. And whether this is due to hyperperfusion of the brain or a risk indicator, as I talked about earlier, it is not known. So it's not known if it's causally related to cognitive decline. So with respect to lipid lowering, we know that in elderly without dementia and with cardiovascular disease, statins reduce risk of cardiovascular events. In older people without cardiovascular disease, the evidence is scarce and there's no or limited effect of statins on reducing risk of events. PROSPER, next please, is the only trial on statins in an elderly population. And they found a slight risk reduction on cardiac events. They showed no effect on stroke risk. There was no effect on progression of white matter hyperintensities, and statin therapy had no effect on cognition. With respect to the effect of stopping statin therapy in the elderly, a recent observational study showed that discontinuation of statins was associated with an increased risk of cardiovascular events. However, no data was available on cognitive endpoints. And since it's an observational study, the results could be due to confounding by indication. Next, please. But again, patients with dementia were excluded from these studies. And evidence of the effect of statin therapy in dementia is non-existent. So to summarize, blood pressure and cholesterol levels decline with age and disease, and there is no or limited evidence on whether treating these cardiovascular risk factors prevents further cognitive decline. And we do know that dementia patients have reduced life expectancy, and which has, of course, an effect on goals of treatment and care. So in other words, dementia patients are not presented in the guidelines we all use for cardiovascular risk management. And the treating physician has to target treatment based on, as I said, remaining life expectancy, the time to benefit of a treatment, whether a patient has prevalent cardiovascular disease or not, if there are other comorbidities, if blood pressure levels are still high and cholesterol levels are still high, the side effects of treatment, and of course the wishes of the patients. So all these factors have to be integrated in a multidisciplinary care program. So a physician has to take care of these factors and integrate them in a care program based on impairment in multiple domains, whether it is important to treat the heart, but also the brain. And there is not a guideline to treat these patients yet. So I think if we want to know more about the effect of cardiovascular risk management to prevent further cognitive decline, studies in these patient populations are needed. So next slide. In conclusion, there are optimal time windows for targeting risk factors to prevent cognitive decline and dementia. And we suggest to use public health programs at younger age, specific programs, as Edo was talking about, for high-risk groups, maybe at middle age or a little older, and multidisciplinary targeted care for specific patients at older age. I think this was our presentation, and we have still a little time for discussion before the last talk in this program. So Edo, do you want to start with the discussion?
Yes, thank you, Marion. Thank you for this putting things excellently into perspective from somebody who's not only an epidemiologist and a scientist, but also a clinician, and you really see the value of having both roles here. So you raise a very important point that actually people who you were talking about are not represented in clinical trials. So we do not have any evidence so far. So what would you suggest would be the solution? Should we repeat all these trials in frail older people or frail older people with cognitive impairment? Should we in some kind of way try to integrate all our knowledge from observational studies, which is heavily confounded by indication, as you already said, when it concerns treatment? Should we integrate that with all we know from trials in actually very different populations? What would be the solutions? How do we provide proper guidelines for the populations that you were talking about?
Yeah, this is an excellent question. And I think repeating all the trials we already did in the healthy population is probably not the way to go, because the population I am talking about, the older patients with already cognitive impairment, is very heterogeneous. So you need large sample sizes to, I think, get good results and reliable results. So I think you need another way, and probably more pragmatic studies with like a targeted treatment based on all the risk factors you see in a patient, and then just follow them up and see if there is any effect on patient-related outcomes. So not the outcomes we use in trials like death or cardiovascular events, but more quality of life, autonomy at home, care consumption. So experience-based medicine, which we know is not very easy, and it's very difficult to have any causal inferences, of course, from what you see in your consultation. But I agree with you that such a pragmatic approach at this moment is probably the best way forward. I see that John raised his hand. So John, please.
Well, first of all, thank you for excellent presentations and very balanced ones as well, I think, which we don't always get sometimes with prevention. So that was really great to see. I wanted to sort of both support and also ask you a bit more about the issue of timing, because I do agree with you, it's absolutely critical. And as a sort of comment, and Ido, you know this study well, but in the Prevent Dementia study that Craig Ritchie leads, we've been looking at this middle-aged cohort at risk of future dementia. So in terms of brain imaging, we showed that at an average age of 52 years, this cohort, so sort of midlife, that those at future risk of dementia didn't have increased vascular burden at that age. But when they were followed 2 years later, and this is work that Audrey Lowe has recently published, they did show some evidence that the high-risk group had increased sort of vascular change over a 2-year period. So that sort of suggested, or one interpretation of that, is that maybe at that age, we're just at the sort of tipping point whereby you're starting to get increased burden, which would suggest that early 50s would be the right time for interventions aimed at sort of white matter lesions and subcortical vascular change. But I just wondered what other evidence we have for sort of trying to determine the optimal age for these interventions.
Yeah, it's a very good point. And for cognition and dementia, I think it may actually be impossible to delineate the effect when you target people in their 50s. But you could also argue there's so much evidence that targeting blood pressure, particularly blood pressure, but also high cholesterol in this age group to prevent cardiovascular disease within the next decade or so. And there's so little questions about whether this is effective that maybe in this type of populations, we should not strive anymore for really proving beyond any doubt that this is also beneficial for cognition and prevention of dementia. But you could argue that we should focus a bit more on the populations in which we are uncertain, and maybe aggressive treatment of blood pressure to targets of 120 may be beneficial for short-term prevention of stroke and myocardial infarction, but may eventually be detrimental for cognition on the longer term. And this is really a question that we need to answer. So I think any trials using cardiovascular outcomes as primary outcome should continue observational extension for cognition to really see if the beneficial effects on the short term for the prevention of cardiovascular disease and death outweigh the possibly detrimental effects on cognition and dementia on the long term. But I don't have the final answer to this question, John. It's extremely difficult.
And there's one question of Christopher Chen on should we be trialing more stringent targets, for example, blood pressure below 120, a minimum amount of physical activity, and add in other factors such as social interaction, cognitive training for prevention studies. Edo, do you have an answer for that? And maybe after this question, we go to the early career researcher presentation.
Yes, thank you, Chris, for this excellent question. I'm reluctant also from what Mayon said, particularly when we target older people. I mean, we're not talking about frail people in their 90s. It's clear that in those people, you should be very restrictive and probably deprescribe, as Mayon said, to benefit patients. But if we talk about people in their 60s and 70s, who knows, maybe an even more stringent blood pressure target could be beneficial, but you really very quickly get to the limit where you evoke side effects. And so the question is, how much further benefit could you expect from going lower, and how much higher will the risk become of getting side effects? And as for the other factors, I think you're right. Things like social interaction and physical activity are probably very important, although this is also only known from observational studies. So it's very uncertain whether there are any causal relationships. As for cognitive training, I'm always ambiguous about that. If you add in cognitive training and you do short-term trials, 1 or 2 years follow-up, you will inevitably detect learning effects. So if you do a multi-domain intervention and have cognition as one of the interventions, and you find a very small effect on cognition over 1 or 2 years, I'm not very sure that you actually interfered with the disease process. And this may not last, this effect, over years. So I am reluctant with using cognitive training in such an intervention unless you do a very long-term follow-up and really show that you prevent decline instead of actually improving cognition. I don't know if that answers your question approximately.
That's terrific, Edo. Thank you.
Okay, well, thank you all for your active participation in the discussion. And as Mayon already suggested, I think it's a good moment to move on to our final presentation of this session. And this will be given by Daria Gutteridge. And she will talk about a systematic review into the relationship between blood pressure variability and gray and white matter structures. So Daria, please.
Thank you very much for the introduction and great talk. So to start, I'd just quickly like to explain what I actually mean when I talk about blood pressure variability. So if you could please go to the next slide. So there are different measurements of variability, including short-term blood pressure variability, which is usually measured over an ambulatory blood pressure machine and looks at fluctuations in blood pressure across a 24-hour window. And this also includes the circadian patterns of blood pressure, so the night fall of blood pressure and the increase in blood pressure in the morning. And then there is midterm blood pressure variability, which looks at fluctuations across days. And then there is long-term blood pressure variability, which refers to fluctuations that occur across months or years. So for this review, we included all those types of blood pressure variability. So what is currently known? So recent research has really shown that blood pressure variability plays an independent major role in cardiovascular health and also in the development of cognitive impairment. There have also been 2 recent meta-analyses that have shown a link between blood pressure variability and cerebral small vessel disease. However, the relationship between blood pressure variability measures and brain structures are currently not really well understood. So this is where our systematic review comes in to better understand the role that blood pressure variability may play in neurodegeneration and cognitive impairment. So for this review, next slide, please. So for this review, we followed the PRISMA guidelines and looked through 3 different databases, including any studies that looked at the relationship between blood pressure variability and brain structural MRI measures. And we checked a total of about 6,500 individual records, of which over 300 entered full-text screening, leading to a total sample of 20 studies, 11 of which looked at short-term blood pressure variability and 8 investigated visit-to-visit blood pressure variability. And then there was an additional paper that looked at the composite measurements. So as blood pressure variability measurements, as well as the study samples, really differ between the different studies, between those 20 studies. Meta-analysis was unfortunately not possible for us. So I'm trying to summarize the results as good as I can about that. So results in regards to short-term blood pressure variability. So nighttime blood pressure variability was consistently found to be negatively associated with the whole brain volume. So 3 studies looked at that, and hippocampal volume, whilst daytime blood pressure variability appeared less important across the 3 studies, with only one of them finding a significant effect. The results for blood pressure dipping were more of mixed nature, with 4 of the 7 studies finding an unfavorable association between decreased dipping patterns and brain structural integrity. And then the long-term blood pressure variability results. Sorry, the studies, like I said, really differed. So the interval between those measurements ranged between 3 months and 11 years, and the duration of the whole assessment ranged between 3 to 33 years. Overall, we found that systolic blood pressure variability was consistently associated with decreased hippocampal volume in all the 6 studies that looked at this. Furthermore, increased systolic blood pressure variability was also linked with decreased whole brain volume and with decreased grey matter volume, as well as with decreased white and grey matter volume. It was also interesting that 2 of the studies used diffusion-weighted imaging to look at the microstructural white matter integrity, with both studies finding a negative relationship between long-term blood pressure variability. Our study stood in particular out because we looked at a sample of over 2,000 participants for this. So this is particularly interesting because white matter imaging, so diffusion white matter imaging, is more sensitive often in detecting white matter abnormalities before, for instance, white matter hyperintensities are shown in MRI imaging. So to summarize, increased blood pressure variability, in particular systolic long-term blood pressure variability and systolic nighttime blood pressure variability, are linked with reduced brain volume and hippocampal volume. Next slide, please. So there were also some gaps that I would like to highlight that we found. So in particular, midterm blood pressure variability and morning blood pressure variability, we couldn't find any studies that investigated this in regards to any of the brain structural imaging. Also, there was limited research into white matter microstructural integrity, so diffusion-weighted imaging. So to summarize, these findings suggest that blood pressure variability is linked to brain atrophy, and this could suggest that it may be also be linked to neurodegeneration, which can contribute to a better understanding into the pathological link between blood pressure variability and cognitive decline. Beautiful, thank you.
Thank you, Daria, for this excellent presentation and very interesting. I see no questions in the chat. So let me start with a question. Could you elaborate about possible mechanisms relating the blood pressure variability to brain pathology and maybe cognitive decline?
Yeah, that's a tricky one. So yeah, that's the question sort of that is currently really not all too well understood, I guess. So I mean, there are different mechanisms that play part in it. So I think neurodegeneration could definitely be a cause. If the vessels are not, so through the fluctuations, the blood vessels may exposed to more pressure than they should be, which can also lead to abnormalities within the blood vessels, I guess. And that might then link to the neurons not getting enough blood flow to when they need it. So that could probably then contribute to neurodegeneration. Having said that, all of this is obviously a bit speculative in regards to the systematic review, because we can sort of only say that we found an association between increased blood pressure variability and brain atrophy, or like reduced volume in those areas. So the underlying reason for this, I think the systematic review can't really resolve the answer completely.
Yeah, okay. There are a few other questions in the chat. Fatime asks, is there a reason for why hippocampus is vulnerable? Any links with mechanism of transient global amnesia?
I'm not sure about amnesia itself. I just know that, I mean, obviously, first of all, I would like to say it's also, most of the studies looked at hippocampal volume, so it was just the region that was mostly investigated. So that's the reason why, yeah, maybe other regions are affected by it as well. The hippocampus is obviously of great importance because it's really linked to cognitive functioning and also to Alzheimer's. So that's why we're really interested in the region, but also the hippocampus is really sensitive to blood supply in general. So that might be an explanation why the hippocampus is affected by it.
Okay. And then Naomi Starmans asks the different indices for brain volumes and which indices is the most reliable, or should we focus on?
To be honest, I can't give you a good response.
The indices of blood pressure variability, she says. So which of those is most reliable?
Okay, so at the moment, blood pressure variability is a bit of a loose term. Like I said, it can refer to lots of different measurements. I think clinical value-wise, the short-term variability or mid-term variability provides much more clinical value, because if you look at long-term blood pressure variability that is measured across years, it's just difficult to implement it into clinic. So I think, I personally think short-term blood pressure variability is much more promising in this regard. And based on this systematic review, because there hasn't really been any study, I looked at mid-term blood pressure variability. I can't comment on mid-term blood pressure variability. In regards to short-term blood pressure variability, it really looks like the fluctuations during the night. So that is not just referring to the actual dipping, it's the fluctuations that occur during the nighttime seem to be in particularly relevant.
Yeah. And do you think, like as a clinician, I'm curious, do you think this blood pressure variability should be integrated in care? Should we do 24-hour blood pressure measurements more often to well, target the right people? What do you think?
I personally think yes. It would be great if everyone that receives medication would receive a 24-hour monitoring first, to really see, because some people that for our study that we're looking at, they show much more an increase in blood pressure during the night, and their blood pressure during the day is fine. So it just doesn't cut it to just assess it in clinic itself. In regards to medication, there have been some studies that have shown that calcium channel blockers are more effective in regards to reducing variability than other medications. But I think there is a bit of a mixed research in this regard as well. So I think it still has to go a long way till we can actually implement it into clinicals. At the moment, it's also not knowing what is a good fluctuation, what is a bad fluctuation, and fluctuation is statistically not always the same investigated as well. So there's still lots of problems to be resolved before it can really be implemented into the clinic. But I think it definitely looks like a promising feature to be included in the future. Yes.
Yeah. And there's one question popping up. Are nighttime blood pressure variability related to sleep disorder and OSAs, which also affect cognition? So do you have any information on that?
Well, I mean, especially disorders like sleep apnea really affect your blood pressure during the night. So actually, most of the studies that investigate blood pressure variability in regards to cognition, they often exclude people with sleep disorders and sleep apnea. So I think this might not be covered in this review or in lots of the studies that look at it, because sleep disorders do affect your blood pressure during the night. Absolutely.
Yeah. Yeah, if you don't sleep, the blood pressure is higher during the night. So it could also be the other way around. Are there any other questions from the floor? Edo, do you have a question for Daria?
No, I think these were excellent points raised by the questions, and I think we have to wrap up the session because we're 1 minute before 11. So I would like to thank Daria and thank you, Mayon, of course, for co-chairing this session. And again, thank the organizers for inviting us to have this session. And I'd like to give the floor back to Raj and you.
Thank you very much, Mayon and Edo. Well, I think that's an excellent session. And I think Daria had good questions. and she supplied wonderful answers too. So we appreciate that very much.